Dear students, Assalamu alaikum. In the last lecture, we studied about the basic principles of osmosis and osmotic equilibrium. The objectives of today's lecture are to learn about clinical abnormalities of fluid volume regulation, edema, and safety factors of edema. As discussed in a previous lecture, significant clinical abnormalities of fluid volume regulation can result in patients if osmotic equilibrium is not maintained in intracellular and extracellular fluid compartments. To assess these abnormalities, we need to know the osmolarity of body fluids. However, plasma osmolarity is not routinely measured, and plasma sodium concentration is a reasonable indicator of plasma osmolarity because of its ease of measurement. When plasma sodium concentration is reduced, a few milliequivalents below normal, a person is said to be suffering from hyponatremia. Decreased plasma sodium concentration can result from loss of sodium chloride from the extracellular fluid or addition of excess water to the extracellular fluid. Hyponatremia-Dehydration type. Loss of sodium chloride usually results in hyponatremia of the dehydration type and is associated with decreased extracellular fluid volume. The causes of hyponatremia of the dehydration type include diarrhea and vomiting, overuse of diuretics, sodium wasting kidney diseases, and Addison's disease. Hyponatremia of the overhydration type. Hyponatremia can also be associated with excess water retention, which dilutes the sodium in the extracellular fluid. Cause may be excessive secretion of antidiuretic hormone. This can cause the kidney tubules to reabsorb more water, leading to hyponatremia of the overhydration type. Consequences of hyponatremia. Changes in cell volume as a result of hyponatremia can have profound effects on tissue and organ function, especially in the brain. Hyponatremia can be of two types: acute hyponatremia and chronic hyponatremia. Acute hyponatremia is a rapid reduction in plasma sodium concentration. This can cause brain cell edema and neurological symptoms including headache, nausea, lethargy, and disorientation. If plasma sodium concentration rapidly falls below 115 to 120 millimoles per liter, brain swelling may lead to seizures, coma, brain herniation, leading to permanent brain damage and death. This figure shows the brain cell volume regulation during hyponatremia. The top panel shows normonatremia and normal brain size. During acute hyponatremia, there is diffusion of water into the brain cells, causing swelling of brain tissue, indicated by dashed lines as shown in the lower panel. The brain tissue responds by rapid adaptation. During rapid adaptation, brain cells stimulate transport of sodium, potassium, and organic solutes out of the cells. This causes water diffusion out of the cells, leading to reduction of brain swelling. The other type of hyponatremia is the chronic hyponatremia. It occurs when hyponatremia evolves slowly over several days. The brain and other tissues respond by slow adaptation. In slow adaptation, brain cells transport sodium, chloride, potassium, and organic solutes from the cells into the extracellular compartment. This response weakens or slows down osmotic flow of water into brain cells, and there is less swelling of brain tissue. Now, at this point, there is an important clinical consideration that you should keep in mind. The brain is vulnerable to injury if chronic hyponatremia is corrected too rapidly during slow adaptation. The reason is, if hypertonic solutions are added too rapidly to correct hyponatremia, brain cells cannot recapture, I repeat, cannot recapture the solutes which had diffused out earlier during slow adaptation. This may lead to osmotic injury of neurons known as osmotic demyelination. This figure depicts the effects of hyponatremia on brain tissue, also showing rapid and slow adaptation along with osmotic demyelination. The second clinical abnormality of fluid volume regulation is the hypernatremia. Hypernatremia means increased plasma sodium concentration. Now, increased plasma sodium concentration can be due to either loss of water from the extracellular fluid, which concentrates the sodium ions, or excess sodium in the extracellular fluid. Hypernatremia-Dehydration. When there is primary loss of water from the extracellular fluid compartment, this results in hypernatremia of the dehydration type. The causes include diabetes insipidus, nephrogenic diabetes insipidus, and sweating during prolonged heavy exercise. Hypernatremia can also occur as a result of excessive sodium chloride added to the extracellular fluid, and this results in hypernatremia of the overhydration type. The overhydration is because excess extra sodium chloride is usually associated with some degree of water retention by the kidneys as well. Excessive secretion of the sodium retaining hormone aldosterone can cause a mild degree of hypernatremia and overhydration. Hypernatremia is not that severe as compared to hyponatremia. Now the question arises, why the hypernatremia is not severe? The reason is that the sodium retention caused by increased aldosterone secretion also stimulates secretion of antidiuretic hormone, which enables kidneys to also reabsorb large amounts of water. Hypernatremia is also much less common than hyponatremia because hypernatremia promotes thirst and stimulates secretion of antidiuretic hormone, which protects against hypernatremia. However, in spite of these corrective measures, severe hypernatremia can occur in number one, patients with hypothalamic lesions that impair their sense of thirst. Number two, in infants who may not have ready access to water. Or number three, in elderly patients with altered mental status. Correction of hypernatremia can be achieved by administering hypoosmotic sodium chloride or dextrose solutions. Again, it is emphasized to correct the hypernatremia slowly in patients who have had chronic increases in plasma sodium concentration. Now we study the next topic, edema. Edema refers to the presence of excess fluid in the body tissues. It is of two types, intracellular edema and extracellular edema. The causes of intracellular edema include hyponatremia, as we just discussed, depression of the metabolic systems, and lack of adequate nutrition to the cells. In addition, intracellular edema can also occur in inflamed tissues. Inflammation usually increases cell membrane permeability. Extracellular edema. There are four major factors underlying a number of conditions that can cause extracellular edema. The first factor is increased capillary pressure. This can result from excessive renal salt and water retention, as in renal failure, and mineralocorticoid excess, or due to high venous pressures seen as in heart failure and venous obstruction, or maybe due to decreased arteriolar resistance because of excessive body heat and vasodilator drugs. The second factor is decreased plasma proteins, which may be due to loss of proteins in urine or loss of protein from denuded skin, as in burns and wounds, or failure to produce proteins like in liver disease or in protein malnutrition. The third factor is increased capillary permeability. This may occur due to immune reactions, toxins, bacterial infections, vitamin deficiency, prolonged ischemia, and burns. The fourth factor is blockage of lymph return. The causes may be cancer, infections by parasitic microscopic worms, surgery in which lymph vessels are removed or may be obstructed, and congenital abnormalities. This figure shows blockage of lymph flow causing elephantiasis of the lower leg. A closer look at the elephantiasis. There are few safety factors preventing edema. The first factor is low compliance of the interstitium in the negative pressure range. The compliance of the tissue is defined as the change in volume per millimeter of mercury pressure change. Now, the interstitial fluid hydrostatic pressure in most loose subcutaneous tissues of the body is about -3 millimeter of mercury. Now, as long as the interstitial fluid is in this negative range, small changes in interstitial fluid volume are associated with large changes in interstitial fluid hydrostatic pressure. To understand this, have a look at this diagram. The figure shows the relation between interstitial fluid hydrostatic pressure and interstitial fluid volume for loose tissues. You can see that large amounts of fluid occur only when the interstitial fluid pressure becomes positive. So, once interstitial fluid pressure rises above 0 mm of mercury, the compliance of the tissues increases markedly, allowing large amounts of fluid to accumulate in the tissues. Therefore, in the positive tissue pressure range, this safety factor against edema is lost because of the large increase in compliance of the tissues. The safety factor contributed by low tissue compliance is 3 mm of mercury. The second factor, safety factor, is increased lymph flow. This allows the lymphatics to carry away large amounts of fluid and proteins in response to increased capillary filtration, preventing the interstitial pressures from rising into the positive pressure range. The safety factor contributed by increased lymph flow is 7 mm of mercury. The third safety factor is washdown of interstitial fluid proteins. The protein concentration of the interstitium decreases as lymph flow is increased because large amounts of proteins are carried away in lymph. The safety factor from this effect has been calculated to be about 7 mm of mercury. Adding the values of all safety factors, the total safety factor against edema is about 17 mm of mercury. This means that the capillary pressure in a tissue could rise by 17 mm of mercury before edema would occur. With this, I end today's lecture.